Our lecture today is about occlusion and malocclusion. So this is the first lecture in the orthodontic residency program. So let's start by defining orthodontics. It came from the Greek word ortho means straight, while dontics mean tooth or teeth. So orthodontics means straight teeth. So basically, if you want to define it, it's a specialty of dentistry concerned with the management and treatment of malocclusion. So what is occlusion? Occlusion is the arrangement and position of teeth with the upper and lower teeth in contact in their usual position. So what is normal occlusion is the occlusion within acceptable deviation of an ideal and does not constitute an aesthetic or functional problem to the patient. So basically, normal occlusion in which this occlusion is not causing any problem to the patient, neither aesthetically nor functionally. In the majority of the cases, malocclusion does not itself represent a disease. It's not a disease. It's just a variation from what is considered as a normal. So if we want to study occlusion, we need to study static occlusion and functional occlusion. And in the work in orthodontics that is studied, static occlusion is done by Andrews, and he came up with the 6 keys to normal occlusion. And the functional occlusion was done by Roth, and he came up with the mutually protected occlusion. So we're going to start first by the static occlusion. The first one to describe the static occlusion was angle. An angle classified a malocclusion according to the molar relationship. And he suggested that normal occlusion was based fundamentally around the position of the first molar. So if you get your first molar into class 1 angle classification, then all the other teeth will be aligned properly. So if there was a correct relationship between the teeth occupied between molars on both sides, it have a smoothly curved line and normal occlusion will result. So simply put the K-molars in a class 1, and this is still valid until now. If you put your K-molars in a class 1 and then align the teeth, the malocclusion will be resolved and we will have an normal occlusion. But then we needed a little bit of more details. So Andrews came in and he had his 6 keys to normal occlusion. So how did Andrews came up with these 6 keys to normal occlusion? What he did, he studied 120 casts of non-orthodontic patient with normal occlusion. So these were a model, all right, because Andrews used to work in California and there's a lot of the house of a lot of models. So he picked up 120 models who never had an orthodontic treatment at all, and their teeth were straight and pleasing in appearance. So they looked at the teeth, they were looking good, and the bite looked generally correct with no incorrect bite as judged by Andrews. So, and as well, Andrews find that this patient will not benefit from orthodontic treatment. So again, what Andrews did, he looked into a 120 cast non-orthodontic patient, never had an orthodontic treatment, so natural smile, found their teeth attractive and pleasant, no bite problem, and they will not benefit from any orthodontic treatment. So the crowns of these collection was studied intensively by Andrews. He looked to many characteristics, so many characteristics of the crowns, angulation, inclination, spacing, so many characteristics. And he came up with these characteristics of the occlusion that was presented in most of this sample, not necessarily presented in all the casts, and presented in most of them. And then he wanted to see which one we need to use. So he decided to validate these results. So he went to the cases that is presented in the national meeting on the American Orthodontic Conference. So in the American Orthodontic Conference, usually people who set the American board, they present their cases. So he studied the cases that was presented from 1965 to 1971 with a total of 1,150 cases. And he saw which of the characteristics that he proposed was presented in most of these cases. And he came up with the 6 characteristics of a normal occlusion. However, you need to know that even in the cases that Andrews studied, it was not presented in all of these 6 cases. It was not there all the time. So, but basically, and generally speaking, we aim to have these 6 keys of normal occlusion whenever we treat our patient. So what are these characteristics? The first one is the molar relationship. He came up with Andrews class 1. He said the distal surface of the distal margin, so this one, distal surface of the distal margin of the upper first permanent molar should occlude with the mesial surface of the mesial marginal ridge. So distal surface of the distal marginal ridge of the upper 6 should occlude with the mesial margin of the mesial marginal ridge of the lower 6. And the mesobuccal cusp should be sitting in the groove between the mesobuccal cusp and the distobuccal cusp in the lower molar. So in order to get, which coincident or like which go through with what is suggested by angle for a normal occlusion. So in order to get a normal occlusion, the first key is to get the molar into class 1. Now the second key is the crown angulation, or what we call it the mesodistal tip, or what we call it the second order bend. He said that the gingival portion, which is this part of the crown, of the length axis of each tooth crown, should lie distal to the occlusal portion of that long axis. So that means that the teeth should be mesially tipped. So again, if you looked at this one, which is the gingival margin of the long axis, or the gingival part of the long axis of this crown, should lie more distal in comparison to the occlusal surface or occlusal part of the long axis of the clinical crown, which means that the tooth should have a mesial tipping. And this mesial tipping is different from tooth to tooth. For example, the central incisors has more mesial tip compared to the lateral, and less than what is represented in the canine. So each tooth has its own tip. And then he said the crown inclination, and here we have to distinguish between angulation and inclination. Angulation means mesodistal tip, while inclination means labiolingual or buccolingual torque. So he said the crown inclination or the labiolingual torque of the upper incisors at the occlusal portion of the crown labial surface is labial compared to the occlusal surface. Okay. However, the rest of the teeth, so only the incisors, they have what we call it the positive torque, which basically the labial surface or the occlusal surface or the occlusal portion of the labial surface is more labial than the gingival portion of the labial surface, which basically means that the root has to go palatal and the incisor has to get a positive torque. So only the incisors has to have a positive torque. While canine and posterior teeth, usually the gingival portion, which is this one, should be more buccal of the crown compared to the incisal portion, which means that the root has to go in a more buccal direction, which means a negative torque. The fourth key was that teeth should have no rotations, no rotation presented, no spacing is presented, and the curve of spee should be flat curve of spee. So Andrews came up with these 6 keys to normal occlusion, and he said whenever you treat a patient, you should be aiming to treat to these 6 keys of normal occlusion. Then Bennett and McLaughlin, who came up with the MBT system with Tivais, they came up with something we call it the 7th key to the normal occlusion, which basically the correct tooth size, which means if you have a big incisors or big teeth in the maxilla compared to a smaller teeth in the mandible, you will never have a fit between the upper and lower teeth. For that reason, you need to check the discrepancy between the size of the maxillary and mandibular teeth. And one way to do that is to use Bolton analysis, in which you check if there's any discrepancy in the size between the upper and lower teeth, or to use the simplest method, which basically you check the mesodistal width of the upper lateral compared to the mesodistal width of the lower lateral. If usually in a normal dentition, the upper lateral should be bigger than the lower lateral, but because we know the most common tooth to have a variation in the size is the upper laterals, they might be smaller or bigger than the lower lateral. So simply, you hold this lateral incisor, the upper, in the cast against the lower incisors. Normally, they should be bigger, which is normal. But if the upper lateral is equal size to the lower lateral, it means that the upper lateral incisor is smaller than usual. Or if the upper lateral is smaller than the lower lateral, again it means that the upper lateral is smaller in size. And if we want to get the teeth into perfect occlusion, then we have either to build up the upper lateral, make them bigger, or make the lower incisors smaller so that we get a perfect fit. Without doing that, we will never get the perfect fit between the upper and lower teeth. The second thing that you can use to check is the mesodistal width of the second premolar in the lower arch, which is the second most common tooth to have discrepancy in the size. Usually it should be equal to the size of the upper 5. So lower 5 should be equal to the upper 5. If the lower 5 is smaller, it means that we have a tooth size discrepancy in which the mandibular teeth is smaller than the maxillary teeth. However, in practice, orthodontically treated occlusion seldomly achieve all these keys. Usually they achieve most of these keys, but not always to achieve all of them. And that's something in the clinic what I want to do is to target to achieve these 6 keys in normal occlusion. We can do them, but I just wanted to know sometimes when you have a severe malocclusion, it's not always possible to achieve the 6 keys of normal occlusion. We might be able to achieve most of them, but not all of them. So now we've finished talking about the static occlusion. What about functional occlusion? So before going into the mutually protected occlusion, I just need to describe certain definitions. The first one is the retruded contact position, or what we call it the centric relation, which is basically a term that describes the position of the mandible in relation to the maxilla when the condyle is in the most stable and reproducible position. Now, back in the time, we used to think that this one is the most posterior superior position of the condyle. However, now it's changed to be the most anterior superior condylar position rather than most posterior superior. So the new one is the anterior superior position. Now we have the intercuspation or the centric occlusion, which is basically the occlusion that occurs with the teeth in position of maximum intercuspation. Call it the intercuspation or the centric occlusion. Then we have something we call it canine guidance and group function guidance. Canine guidance, basically when the patient is doing sliding from on the left side or the right side, sliding to the side, lateral movement, the only tooth that has a contact is the canine. We call this a canine guidance or cuspal raise sometime. While the group function guidance is during lateral movement, the load will be distributed between canines and premolars. So there's several teeth on the working side, they're having a contact. We call this one group function guidance, while this one is called canine guidance. So what is the mutually protected occlusion that is suggested by Roth? Whereby that meaning that the teeth of the anterior and the posterior teeth protect each other in function. So it's mutual protection. So anterior teeth protect the posterior teeth protect the anterior teeth. However, how a mutually protected occlusion is achieved? First, posterior teeth will disocclude in the lateral and protrusive movement, and that will be due to the either the anterior teeth during, we call it the anterior guidance, so during the protrusive movement we'll have a disocclusion in the posterior teeth. In the lateral movement we have a canine guidance in which it will cause disocclusion of the teeth. However, this one should be associated with no contact on the non-working side. So what does that mean? So when the patient is doing a lateral movement like this one, all right, we have a canine guidance, so we do a lateral movement, we have a disocclusion on this side. On the other, this is called a working side. Now on the other side, for example, if this is the right, on the left side, we have the non-working side. In the non-working side, there should be no occlusion as well. But if we have a contact, we call it a contact on the non-working side. So in the mutually protected occlusion, we should have no contact on the non-working side. So basically, when the patient is achieved, how the anterior teeth is protecting the posterior teeth, that during lateral movement, we either going to have a group functional guidance or canine guidance, that the teeth on the other side are protected from each other, from attrition, causing attrition from each other. While when the patient is doing a protrusion in the anterior movement, the incisor guidance will do sliding movement and having non-working side, no contact on the non-working side on the posterior teeth on the right or on the left. By that, the anterior teeth is protecting the posterior teeth. So again, anterior teeth is protecting the posterior teeth when the patient is doing protrusion forward, so the incisor guidance will cause disocclusion of the posterior teeth. On the lateral movement, whether a patient has a canine guidance or a group function guidance, we will have a no contact on the non-working side, which means that that side is protected either by the anterior or by the group of the function. So how the posterior teeth protect the anterior teeth? When the patient is biting, we'll have a posterior teeth in the intercuspal position. We will have a simultaneous bilateral contact of the posterior teeth in the intercuspal position with the incisor teeth slightly out of contact. So basically, the whole load, the whole force will be absorbed by the posterior teeth and preventing heavy force of mastication from hurting or like causing damage to the incisors. Also, in the mutually protected occlusion, other than that we don't have a non-working side contact, incisal guidance, and simultaneous contact between the posterior teeth just before the anterior teeth to protect them, the ICB, which is the intercuspal position, should coincident with the retruded contact position. All right. So basically, when the patient bites and the condyle is the most anterior and superior position, the most reproducible position, it should be the same position as the intercuspal position without any sliding, and displacement. However, this one should be associated with slight freedom for the tooth to start the movement into the sagittal and the horizontal plane. So now all of this mutually protected occlusion was suggested by Roth, but does non-orthodontic patient have the mutually protected occlusion as suggested by Roth? The study of the 120 cast of the non-orthodontic patient that is done by Andrews showed that very few of them have mutually protected occlusion. All right. While in the population, they did a random study and they examined patients randomly, and they found that 91 of them have a non-working side contact. So when we discussed the working side, when we said that the patient is sliding the mandible forward or moving the mandible to the right, on the left side, which we call it the non-working side, there should be no contact according to Roth. However, 91 of the population that examined on that sample have a non-working side contact, which means when they slide on the right, there is a contact on the left. And when you see these patients, there's no problem with them. There is nothing affecting them. So why to achieve mutually protected occlusion? So then the question is, should the ICB and the RCB coincide with each other? Should the intercuspal position should be coincident with the retruded contact position as suggested by Roth? Now, everybody has an agreement that ICB and RCB should coincide. However, larger disagreement on how closely they should coincide, which means if there is a discrepancy between them, a huge discrepancy, 5-6 millimeter, everybody agrees that this will result in a TMD problem and it should not exist. But how much discrepancy between the ICB and RCB is considered acceptable, that's a disagreement. Because when they examine patient in a sample in which they have a displacement or discrepancy between the ICB and RCB of more than 2 millimeter, prior to the orthodontic treatment, they found 20% of this sample having this problem with no any evidence that they have any TMD problem or any harmful. So what they did here again, they examined the patient who would like to go for orthodontic treatment, and they found 20% of those patients who are seeking orthodontic treatment having a discrepancy between the ICB and RCB of more than 2 millimeter, and even though with this discrepancy they did not have any problem. So again, having a discrepancy between the ICB and RCB did not result in a problem. But this is not what Roth said. Roth said that TMD, which is temporomandibular joint dysfunction, an orthodontic relapse is due to the ICB-RCB discrepancy. But as we can see, that this is not an evidence-based thing. Now, when we consider a significant discrepancy, it is when the AB discrepancy is more than 1.5 millimeter or a lateral discrepancy is more than 0.5 millimeter. So to summarize the thing, if the RCB and ICB are not coincident with each other with a huge amount, that will definitely cause a problem. But the disagreement on the smaller amount. So if the patient has a smaller discrepancy, that does not necessarily mean that he will have a problem in the future. Now, there is an agreement that significant discrepancy is present when the AB discrepancy is more than 1.5 millimeter and the lateral discrepancy is more than 0.5 millimeter. So, because we are talking now about functional occlusion, and the only way to examine functional occlusion is to use articulator. So, should orthodontists use articulator? Well, a study done in the US, they found that although 13% of the orthodontists routinely mount the pre-treatment study model on the articulator, only 6.5 of them will look at the end of treatment articulation to see if they achieve the treatment goals. However, and as well, if you articulate the study model, it found that it does not affect the orthodontist decision. So basically, if you articulate them, it's not going to change your decision. And if you articulate them at the end of the treatment, you are not going to take another impression and articulate it again. From the evidence that we saw, little kind of effect of the functional occlusion, if any, presented. So why to mount an study model on the articulator? However, this is on the cases that consider simple or moderate cases. However, comprehensive approach, including articulator, should be used when we're doing the diagnosis and treatment planning for a complex orthodontic cases. And then later during the year, we're going to see that complex cases with anterior open bite, for example, or orthodontic surgery. These complex cases need articulator. So how important is the functional occlusory plane? Now, there is a claim that it is necessary to finish in a mutually protected occlusion to avoid TMD, periodontal breakdown, and to achieve a long-term stability. So basically, if you don't achieve functional occlusion, you get TMD, periodontal breakdown, and occlusal instability. However, there is no single type of functional occlusion seems to be predominant in the natural dentition, making it really debatable to what is the ideal functional occlusion. So now, okay, I make it simple. I wanted to do a functional occlusion. I am very excited. I want to do a functional occlusion. Then I want to know what is functional occlusion. What is considered ideal functional occlusion? So you go to examine the patient who did not have an orthodontic treatment as Andrews did. And then you don't find that all of these people have the same functional occlusion. They're all different. So now we have a debate on what is ideal functional occlusion. And as we mentioned before, like a lot of patients, they have a non-working side contact. Another study mentioned that 70% of the population, they have a non-working side contact. But before that, we said that Roth said we should not have a non-working side contact, but then it's present in the population. Why not to consider this as a normal? So here is the debate. However, as well, the difference of greater than 2 millimeter has been also reported between the retruded contact position and intercuspal position for almost 40% of the orthodontic patient. When they attended treatment, they have this discrepancy, which is less than 2 millimeter, greater than 2 millimeter, with no problem. So again, why to consider that RCB and ICB should be coincident if it does not cause a problem? So basically, there does appear to be a relationship between TMD and large slide between RCP and ICP. So we know that if we have a great shift between the retruded contact position and intercuspal position, we're going to have a TMD, a huge shift. But if a minimal shift, it might be acceptable. We don't know at the moment because it is present with a normal population, causing no problems. Although the correlation between other traits of malocclusion and TMD are generally weak. So we don't, for example, anterior open bite, we'll expect a patient with anterior open bite or crowding to have more TMD. No, there is nothing. It's weak. The association is weak. The strongest one, which is still very weak, is the difference between the RCP and ICP. While crowding, increased overjet, none of these has linked to TMD. So to summarize it a little bit more, if the patient has a huge shift between RCP and ICP, there is some link and evidence that might cause a problem with a TMJ or a TMD. Other than that, there is no evidence to suggest that any kind of malocclusion can cause TMD. So if nothing can cause TMD from the malocclusion, then what is the importance of the functional occlusion to be achieved to guarantee that there will be no TMD? If already patient who has an increased overjet anterior open bite has no TMD problem. So the question to ask now, by treating patient to the ideal functional occlusion, does that eliminate or reduce TMD? Well, the answer is no evidence to support this claim. So again, if you treat the patient to the ideal functional occlusion, does that result in a more stable result as claimed by Roth? The question again, unfortunately, it's not guaranteed. You can't guarantee long-term stability just because you achieved functional occlusion. And here we come to the conclusion of our functional occlusion. Therefore, whilst a treatment should aim for an ideal functional occlusion, if it's not achieved, there do not appear to be a long-term serious consequences to the patient. So basically that's why in the clinic we mount the study model. We use the hand-articulated study model rather than mounting the cast on an articulator. All right, and for sure, leaving patient with displacement or like discrepancy between the RCP and ICP, a huge discrepancy is not recommended. So again, because of all of that, lack of evidence to support that functional occlusion will result in a better TMJ, or even like any malocclusion can cause TMJ. Now we are aiming to achieve an ideal functional occlusion, but if we did not manage to achieve it, then there is no long-term serious consequences. So to summarize occlusion, we have static occlusion, we have functional occlusion. Static occlusion, we should aim to Andrews 6 keys of normal occlusion, at least to achieve most of them. If we could not achieve all of them, because it depends on the start and the beginning of the malocclusion if it's too severe. Functional occlusion, it's a mutually protected occlusion that is suggested by Roth. However, there's no evidence to support this. We should aim to achieve it, but if we did not manage to achieve it, then that doesn't mean it will cause a huge detrimental effect or serious effect in the future. So now we examined so far the occlusion. So what is malocclusion? Malocclusion can be defined as a deviation from the ideal that might be considered aesthetically or functionally unaesthetic or unsatisfactory for the patient. So basically, it's not a disease. Malocclusion is not a disease. It's just deviation from normal, either aesthetically or functionally, that the patient is not happy with. So how do we classify malocclusion? Now, there is two methods of classifying malocclusion. The first one is according to molar classification that is proposed by Angles, and the second one is the incisor classification, which is presented by British Standard Institute. I just want to point out here that molar classification is now the most recognized one internationally, and it's the most common one used in the United States. However, orthodontists trained in the UK, they got used to use the incisor classification because this is the British way of classifying the malocclusion. So what is the molar classification of Angles? Angles classified the occlusion according to the molar relationship. And this is remain, as we said, the most internationally recognized malocclusion. If these teeth were in the correct relationship and the remaining teeth occupied a smoothly curved line, a normal occlusion would result. Again, as we mentioned in the beginning, to achieve a good occlusion, you need to get your molars into class 1. So if you get your molars into class 1 and then the teeth occupy a smooth curved line, we will have a normal occlusion. Definitely no overjet, no reverse overjet, nothing. So Angle classified the molar class 1 as when the mesobuccal cusp of the upper 6 occluding the buccal groove of the lower 6. While the class 2 when the distobuccal cusp of the upper 6 occluding the groove on the lower 6, or you can classify it as when the mesobuccal cusp of the upper 6 occluding the embrasure between the lower 6 and 5. While class 3 malocclusion when the premolar is occluding in the embrasure in the buccal groove in the lower 6, or the mesobuccal cusp is occluding in the embrasure between the 6 and the 7 in the lower arch. That's all of them classification. So Angle based his classification according to the molar relationship, and he classified malocclusion into class 1, class 2, and class 3. So when he divided into class 1, that means that the position of the dental arches is normal with the first molar in the normal position. So when a patient has a class 1 molar according to the Angle, that means that we don't have an AB discrepancy. The position of the teeth is correct, as we can see here. But the problem could be crowding, for example, or spacing. So as you can see here, molar relationship both sides is class 1. So we don't have an anterior-posterior discrepancy between the upper and the lower jaws. But we could have other problem, because this is the normal AB position, related, for example, to crossbite, related to crowding, related to spacing that is localized to the dentition, not the AB discrepancy. Then he had the class 2 molar relationship, or class 2 malocclusion, which he subdivided into class 2 division 1 and class 2 division 2. But class 2 is the relationship of the dental arches when it's abnormal, with all the mandibular teeth occluding into more distal position to the normal. Okay, and he classified them into class 1 where the upper incisors are protruded, and class 2 division 1, and class 2 division 2 when the upper incisors are protruded. So if you look here at the case, you can see that the molar relationship is a class 2. So when you have a class 2, then it means that we have a discrepancy in the anterior-posterior relationship between the upper jaw and the lower jaw, with the lower jaw in a more retruded position, meaning that the mandible is going posteriorly compared to the maxilla. So here, in this kind of malocclusion, we have an anterior-posterior problem that might be accompanied as well by the local problems like we mentioned in the class 1, like crowding, spacing, crossbite, and all of that. So you are thinking that class 2 malocclusion will be more difficult to manage compared to class 1, because in a class 1 you only have problem in crowding, spacing, while AB position is correct, while in the class 2 you have different problems, and to add on that the anterior-posterior problem. For example, here you can see that patient has a class 2 molar that resulted in anterior increased overjet. While class 2 division 2, where the upper incisors are inclined lingually or retroclined. So you can see here that the molar relationship is class 2. So this is a class 2 malocclusion, and because the incisors are retroclined, Angle classified this as a retroclined teeth. So again, if you have a class 1 molar relationship, then you don't have any problem in the anterior-posterior dimension, but it could be in the transverse, like a crossbite or midline, could be in the vertical, like anterior open bite or deep bite, could be crowding within the arch or spacing. While when it's a class 2, whether it's a division 1 or division 2, you add to the vertical and transverse problem another one in the anterior-posterior. For that reason, class 2 will be more difficult to manage compared to a class 1. And here is a comparison between class 2 division 2 and class 2 division 1 according to Angles. The last one according to Angle is a class 3 classification, which basically when the mesobuccal cusp of the upper 6 including the embrasure between the lower 6 and 7, in which here the dental arches are also, the relationship between them are abnormal, with all the mandibular teeth occluding mesial to the normal. So all the lower dentition is moved forward compared to the upper dentition. So here's the picture to summarize everything. Here the class 1 where everything look normal anterior-posteriorly, but the dentition might have a problem with the crowding, spacing, overbite, anterior open bite, crossbite. Class 2, division 1, where the incisors are average inclination, but the lower dentition is retruded compared to the upper. Division 2, it's again lower dentition is retruded, but the upper incisors are retroclined. Class 3, the lower dentition is protruded. So this is how angle classified. This is class 1, class 2, and class 3. And here is a half unit class 2, and this is a full unit class 2 as well. We said half unit, it means it's cusp to cusp, and this is a class 3 relationship. So again, we said about the classification of the malocclusion, and we mentioned the first method according to the American method, which is now the most internationally recognized method, is according to the molar relationship. The British way is the incisor classification, and you need to remember and memorize this name. It's according to the British Standard Institute, and it's based upon the relationship of the maxillary and mandibular incisor. That's why it's called incisor classification. Now the BSI claim that this is more clinically relevant method of classifying malocclusion. Why? Because it's the claim represent the true reflection of the underlying skeletal relationship and highlight what is often most of the concern of the patient, which are the incisors. So the reason why the BSI suggested this kind of classification, because they said it closer to represent the skeletal relationship, and it highlights the patient's chief complaint. That's why they decided to use it. Orthodontists in the UK as well use the British Standard Institute. So what is the incisor classification? They use the relationship between the incisal edge of the lower incisor and the cingulum plateau of the upper incisor. So basically, this is the lower incisal edge, and this is the cingulum plateau of the upper incisor, which basically the middle third. If the lower incisors lie below the cingulum plateau, that's class 1. If it lies posterior to the cingulum plateau, that's called the class 2, division 1, and the upper incisors are average or proclined with increased overjet. Or if the upper incisors are retroclined, then it's called the class 2, division 2. While if the lower incisal edge anterior to the cingulum plateau, it's called the class 3. So as you can see here, this is class 1, this is class 2, division 2, and here is a class 3. And as we mentioned, it's the same with angle classification. When you have a class 1 incisors, it is normal anterior-posterior relationship, but you could have problems in the other dimension, like vertical relationship, to have an open bite or a deep bite, transverse like a midline, within each arch like spacing as we can see here, or crowding, but the AB is correct. So again, if you see a patient with the class 1 incisor, that means it's easier to treat compared to a class 2 or a class 3 incisor relationship. And here is a class 2 division 1, where the upper incisors are posterior to the cingulum plateau and the upper incisors are either average or proclined, compared to this one, which is a class 2 division 2. So now we know how to classify the malocclusion. What is the prevalence of the malocclusion? And here we need to distinguish between prevalence and incidence. A prevalence, it means if you examine a population, how many of that population will have this thing. For example, if we're going to say about COVID, I'm going to examine now this village who live in there is 1,000 people, 1,000 the number of the population is 1,000. So if I measure them and then found 2% of this population has COVID, now we call this prevalence. Now the incidence is the number of the new cases that is registered in a certain period of time. So again, I go to the same village and say, okay, in the last week, a new 10 cases is registered as a COVID, which means, for example, that this is 0.5% of the population. We call this is incidence. So now we are talking about prevalence, which is how many cases are presented in the population. Now they need to know something. With a new developed community, you have a lot of marriages from different ethnicity, and we call this polygenic population, which basically it means that they have different genetics. A mixture, for example, Caucasian, American white with a Mexican, these have the different genes, and we call this a polygenic. Now the polygenic population, they will have more crowding and more kind of malocclusion. And the cause for that, because simply just think about it as the following. If a patient has a bigger teeth according to the white American population, for example, and he's married to an Asian Chinese who are famous for a small jaw, and the kid got the bigger teeth with a small jaw, so he definitely gonna get crowded. So that we call it the polygenic population. They have more malocclusion compared to kind of like before monogenic population. Now in the US, the National Health and Nutrition Examination, they did examine 7,000 individuals, and they found that 57 to 59% of the population in need for orthodontic treatment, which is a high percentage or high prevalence of the population. The most common problem was incisor irregularity that needed the problem, which was presented in the majority of the adults, with only 34% having a well-aligned mandibular incisors and 45 well-aligned maxillary incisors. However, 20% of the individual also had a marked deviation from the ideal sagittal relationship, which means, like we said, that the most common one is incisor irregularity, but 20% of these had either class 2 or class 3. That's what we mean when we say deviation from ideal sagittal one, and 2% of these having significant disfiguring that needs an orthodontic correction. In the UK, they found that around 35% of 12 years old will have a definite needs of a treatment when they did an examination. When they combine this to the students or the kids who are already under treatment, because they need treatment, they found that 43% of the kids of 12 years old, they need treatment, which is less than the half by a little bit, which means a high demand for orthodontic treatment. So the other question is, do ethnicity affect the type of the malocclusion? The answer is definitely yes. Now, class 2 problems usually common in the Caucasian population, Northern European, Middle Eastern, and Indian, while class 3 are more common among East Asian society, for example, like China and Japan. While Afro-Caribbean population, they usually have an anterior open bite with bimaxillary protrusion. Caucasian population, they have a higher proportion of increased overbite and class 2 division 2 malocclusion. They have a high prevalence of this kind of malocclusion. That was all for occlusion and malocclusion. Thank you very much.